Detection of lesions in dysplastic Barrett's esophagus by community and expert endoscopists. Introduction. Barrett's esophagus is a precursor of esophageal adenocarcinoma. Malignant degeneration of BE occurs typically through a multi-step transition from non-dysplastic intestinal metaplasia, NDBE, to low-grade dysplasia, LGD, high-grade dysplasia, HGD, and finally invasive adenocarcinoma. The annual incidence of early adenocarcinoma, EAC, found in non-dysplastic BE is estimated to be 0.12% to 0.43%. In contrast, the risk of progression from LGD, when confirmed by an expert pathologist, to HGD or EAC is estimated to be 4.7% to 13.4% per patient year. Regular endoscopic surveillance is therefore recommended in patients with BE, although its benefits and adherence to this is currently under debate. The presence of HGD and intramucosal adenocarcinoma is an established indication for endoscopic therapy by means of endoscopic resection, radiofrequency ablation, RFA, or a combination thereof. Any visible lesion in the Barrett segment should be resected for assessment of its histopathological characteristics. In case further endoscopic treatment is indicated, additional endoscopic resection and/or RFA of the remaining flat Barrett segment is recommended because the risk of metachronous lesions is estimated to be up to 30%. Surveillance endoscopies for BE are predominantly performed in community hospitals. However, most experts advocate for the treatment of BE-related neoplasia to be centralized in expert centers. Data to support centralization of care for BE-related neoplasia are, however, scarce. Schölvinck et al. Hypothesized that any additional yield from centralization would, at least in part, be due to the identification of dysplastic lesions. The identification of early dysplastic lesions is crucial because resection of all visible lesions is required before RFA is used so as to avoid incomplete or insufficient treatment. This study therefore sought to evaluate the detection rates of neoplastic lesions in BE by endoscopists from community hospitals and from expert centers, and to assess the predictive factors influencing these detection rates. Background and aims. Endoscopic treatment of Barrett's esophagus, BE, consists of endoscopic resection of visible lesions followed by radiofrequency ablation, RFA, for any remaining flat BE. Because RFA is only justified in flat BE, detection of neoplastic lesions, high-grade dysplasia, HGD, or early adenocarcinoma, EAC, is crucial. The authors hypothesized that the detection of visible lesions containing HGD or EAC would be superior in BE expert centers compared with community hospitals, thereby supporting centralization of therapy for BE-related neoplasia. Methods. Patients referred with histologically proven HGD or EAC to 2 Dutch BE expert centers were included. Referral letters and endoscopy and pathology reports were reviewed for the description of the BE, presence of lesions, and histopathological analysis of target and random tissue sampling. Primary outcome was the endoscopic detection rate of lesions containing histopathologically proven neoplasia, HGD and/or EAC, in community and expert centers. Results. There were 198 patients referred from 37 community hospitals, median referral time 55 days. Detection rates for visible lesions were 60% in community centers, 75% in patients with a biopsy diagnosis of EAC, 47% in HGD, and 87% in expert centers, 98% in EAC, 75% in HGD. Even with HGD or EAC on random biopsies from the index endoscopy, the yield at repeat endoscopy was less than 50% in community hospitals. In 79 patients referred solely because of random biopsy results, a lesion requiring endoscopic resection or surgery was found in 76% by the expert endoscopists. Conclusion. Endoscopists at community hospitals detect neoplastic lesions at a significantly lower rate. These data support the value of BE expert centers for workup and further treatment of BE.